much. Assalamu alaikum jami'an. First of all, I would like really to thank the organizers of this conference, especially Dr. Haq, Dr. Kamal, and Dr. Mustafa, my dear colleagues and brothers. It's always a pleasure to be here again and again. So I'll be talking today about the bladder preservation, what evidence we have really to change our practice and to consider it the trimodality for muscle invasive bladder cancer. So I'll be talking first about the incidence globally and in Bangladesh about the bladder cancer and also the evidence to support the trimodality treatment for bladder cancer to be an option to be offered to our patients. So if you look at the latest incidence, global incidence, and the GloboCan 2022, the bladder cancer ranked about the ninth most common cancers with more than 600,000 new cases. In Bangladesh, you have the new cases according to the latest GloboCan, 167,000, and unfortunately will lose about 116,000. Now, it's not within the top 5 cancers here in Bangladesh, but it ranks the number 18th. You have here more than 1,600 newly diagnosed cases in Bangladesh. Now, talking about the topic, that is muscle invasive bladder TCC cancers, we know the standard of care for many years, it was the radical cystectomy. But now, or 4 years ago, actually, we shifted to the treatment to consider in some patients the trimodality approach, and keeping in mind that our goals are to cure patients and optimize survival, and also the prevention of pelvic failure and distal metastasis, and with the keeping a good quality of life. Now, if we succeed in some tumors, to have the organ conservative approach, like in anal cancer, esophageal cancer, laryngeal cancer, prostate, and rectal cancer. So why not in bladder cancer? So as I mentioned, surgery has been the standard of care for the muscle invasive bladder cancer, but published data for the last few years revealed that trimodality can really give the same overall survival and disease-free survival and preserving the bladder. And of course, when we say trimodality, it is the maximum TURBT. That's why the role of urologist always is very important, and the concomitant chemo-radio, and this is what we call trimodality. Now, there are many publications really to support the use of trimodality in muscle invasive bladder cancer, and this is one of them, the long-term outcome from the Mass General Hospital. We know the Mass General Hospital in the US and Erlangen University in Europe, they were actually the one that really to publish a big number of patients when we consider trimodality. So this is the update analysis for many years actually, and they compared their practice in the 80s and 90s until 2013. And you can see here from this, the many publications, the many trials they were in, trying really to convince us that trimodality can work. And this is, you can see here about the number of the patients and the TURBT, whether it is complete or not complete, carcinoma in situ is there or not, response to chemoradiotherapy, whether patients will have a complete response or a partial response. And also the clinical stage, usually we're talking about T2 and sometimes T3 and even T4 with N1. They were included in these studies. The presence of hydronephrosis, very important as well. And if you see here, the disease-free survival here, 9 years, it's almost 75%. And that is comparable with surgery. And you can see here, over years, they have actually improved the results of treating their patients. This will show you that the response for chemoradiotherapy is important to achieve. and also that will have an impact on overall survival, disease-free survival, and also the disease-free survival, and also the overall survival was really comparable, which is 75% here, comparable to surgery. And at their experience, actually, the risk of salvage cystectomy was 16%. And we'll see in the other articles already published about the percentage of the salvage cystectomy that those patients might need after the trimodality. And this is good to really discuss with your patient about the possibility of the salvage surgery after failure of trimodality. T-stage was very important. As we know that treating patients with T2 is better the outcome than to have T3 or T4. And of course, N0 is better than N1. This is clearly shown in disease-free survival. And the response also to the chemoradiotherapy or trimodality, also very important, whether patients will achieve a few weeks after the completion of the treatment, whether while doing the cystoscopy, just to see the response, if they have a complete response or the incomplete response. This is really very important for the control of the disease. And the value of TURBT, very important, that these patients, before considering chemoradiotherapy, they should go with the maximum TURBT. And here comes really the importance of collaborating with our urologist colleagues. Now, they conclude in this study, with a big study, more than 300 patients, they confirmed that disease-specific survival and overall survival, they are similar to the cystectomy, and the TMT or trimodality should be discussed with the patient. And I think it's a right to patients to know that there are other options if they are fit and nicely selected, that they can give the same results as surgery. So it's a right to patients to know. So best results you can have if you have solitary T2 or early T3, tumors less than 6 or 7 cm, no hydronephrosis, and also patients can undergo TURBT, maximum TURBT, no carcinoma in situ, and also adequate renal function, so patient can receive this cisplatin as well. And we are talking about the most common pathology, which is TCC. We're not talking about adeno or the squamous. So as I mentioned, these you can see it here. The clinical stage is very important. The response to chemoradio, hydronephrosis, presence or absence, tumor-associated CIS, and maximum TURBT. These you have, to take care of before really advising your patient that there is an option of trimodality rather than surgery or besides surgery. So this is a systemic review and meta-analysis, which is a big number of patients, which really showed the long-term outcome after the trimodality. In the TMT patients, about 3,400, and patients who underwent radical cystectomy, about 2,600. And you can see here that again, it was well balanced between both, and T2 and even T3 and T4 were included in these studies. And radiotherapy was given either a split course or continue course, and now most of the practice that to go with the continue the radiotherapy without having the split course. And again, the results that of this meta-analysis, which is very important, that the survival outcome of patients after their trimodality comparing with the surgery are comparable. So, and I think it's the right the patients to know about what options he has, and maybe he can be also a part of the decision-making for his treatment. Now, the need for salvage cystectomy in the Mass General Hospital, it was 16%. But this study, a big one, I mean, the systematic review and meta-analysis with more than 9,000 patients who underwent to trimodality, and it was published in about 73 studies. They confirmed that around 19.2% the chance of the salvage radical cystectomy. And this is really important, again, to share with the patients and within the MDT that probably 80% of the patients still you can have a good local control and survival and to preserve the bladder with the chance about 19 or 20% that patients may later on develop local recurrence or residual disease that they may go for cystectomy. So if you look at the international practice guidelines to support the trimodality, whether we are talking about the NCCN, AUA, ASCO, or ISMO, or ASTRO, you can find it clearly here. This is the latest guidelines from NCCN and stage T2, the bladder preservation. You can see it here. It's category 1 that you may consider it for patients, especially well-selected patients. The points that I mentioned: no hydronephrosis, no carcinoma in situ, the solitary one less than 6 or 7 cm, and also good renal function. Those patients you can really strongly consider trimodality as a treatment. Even not only for T2, but even if you have T3, T4A with N0 and M1, N1, sorry. So again, bladder preservation is an option to be considered, and again, it is category 1. So for patients who will have really an aggressive local disease and where you consider the neoadjuvant chemo or now chemoimmuno after the Niagara study, which was published last year, in which they added Dorvo to the cisplatin and Gemzar and showed increase the overall survival and disease-free survival. And if still the patients will have a complete response, you may consider as consolidation chemo radiotherapy, or if the patient will have a partial response, still chemo radiotherapy can be considered for those patients. And these are the chemotherapy mostly used as concomitant chemo radiotherapy. And the dose, again, the same, like 65 total dose, for 45 to lymph nodes and to the bladder. It did not change for many years. So probably we are practicing that for now more than 20 years. Now, if you look at other guidelines, not the NCCN, the AUA or the ASCO or the ASTRO, again, you can see it here clearly that the after the MDT discussion, the bladder conservative approach is indicated as category 1 as well. And these information, it's good really to share it with your patients while discussion or within the MDT to support the use of the trimodality whenever it's possible. So the recommendations from these guidelines, the European and the American, for patients with a newly diagnosed muscle-invasive bladder cancer who desire to retain their bladder, or patients who refuse surgery, or patients who are unfit for surgery, and for this with significant comorbidities, to go for radical cystectomy. So it is an option to be offered for your patients. And in patients under consideration for bladder preservation therapy, as I mentioned, the most important points to have maximum debulking, and also to make sure that there is no carcinoma in situ. This is again the ISMO and the European Urology Association. The trimodality, it is there as with the strong rating to consider the trimodality as an option for your patients. Now, radiotherapy details did not change a lot. Usually 64 or 65, by mistake 66. Usually we give 45 and 25 bladder with pelvic lymph nodes, and the boost the bladder with the 20 gray, and it is really good to have if you have VMAT or IMRT rather than 3D to treat. So at least the conformity is better and the side effects less. And the evaluation is very important. That's why we have to work within a team with the urologist, because he is the one to do the cystoscopy follow-up later on, and of course, beside the CT scan whenever needed. So these how we will do the VMAT or the IMRT, the conformity for the bladder and the lymph nodes, and usually the bladder is treated empty. So to conclude, trimodality is the standard of care in patients who refuse surgery or medically unfit, and in selected patients, it will give you the same results as surgery, and keeping in mind that probably 20% only the chance for the salvage cystectomy. And as we always say in our practice, multidisciplinary team approach is really needed in our daily practice. By this, I finish my talk. Thank you so much.
Thank you, Dr. Jamal Khader.